Good morning, everybody.
Good morning.
I didn't really give anybody notice for this Doc Talk Live. We're still a work in progress, as I've always been a work in progress. But this morning,
Sure.
I have the pleasure of being with Rodney Tucker. Rodney's an old friend of mine. Used to do the radio show with me. Actually, used to do the radio show without me too.
Exactly.
So I've taken Doc Talk and I've brought it into the
new generation of social media.
Exactly. So if anybody's out there and happen to be watching and they have questions, hopefully I can figure out a way of reading them. But Dr. Tucker is a specialist in palliative and supportive care, and I've been wanting to get you on the show for a while, but this has come up because one of my listeners to Doc Talk Live really pushed me to say, hey, could you do a show on palliative care? And so that's really why we're here. Tell our viewers, what is palliative care? What do you do?
Well, and that's a good question. So palliative care is first and foremost a medical specialty. My primary training is internal medicine, and then board certified in hospice and palliative care. So the specialty of medicine that is palliative care is an interdisciplinary specialty that focuses on both quantity of life and quality of life for patients and their families. It's delivered, as we say, in an interdisciplinary model. So it's doctors, nurses, nurse practitioners, psychologists, counselors, pastoral care, social work, massage therapists, music therapists, who all come together as a team to help improve patients' quality of life if they're diagnosed with a serious illness.
It sounds a lot like my specialty, physical medicine and rehabilitation.
It is.
So how would you distinguish palliative care from, let's say, a physical medicine and rehabilitation physician?
Well, they work there are many aspects that are the same, because in your specialty and in our specialty, you have to look at multi-dimensions of a patient. So where you're looking at probably mobility, pain control, life space, and what how far the patient's able to go, what physical activities, etc. And you do that in an interdisciplinary manner. So you may work with a neurologist, an orthopedic specialist, a physical therapist, a physiatrist, a nutritionist. We do the same thing in an interdisciplinary way, focusing on what we call the 4 domains of suffering, which is the physical, which many times for physicians, that's the easy part, because we can assess pain, nausea and vomiting, fatigue, sleep, etc. But we also focus on the psychosocial, we focus on the emotional, and then we focus on the spiritual. So working together in all 4 of those domains, we add an extra layer of care to patients and their families to basically live as good as they can with the highest quality as long as they can during a serious illness. So one of the things that's very common, and I saw that maybe some of your listeners or folks may have in mind, is that palliative care is concomitant care, which we mean basically alongside curative or other care. So if you're, for example, a patient with cancer, you can have palliative and supportive care alongside your curative treatments. So we focus on sort of the extra layer of care to improve the quality of your life. And what we're finding more and more, and some of the data is coming out now, that if you receive that good care that addresses all 4 of those domains of suffering, you may actually live longer. And you may live the time during this serious illness better able to tolerate your curative or remittive treatments.
You mentioned cancer.
It's one of our most common groups of patients who receive supportive care.
In my world, the type of patient that would get a multidisciplinary rehabilitative approach would be somebody who's had a stroke, somebody's had a spinal cord injury, somebody's had a traumatic brain injury. What are the types of patients that sort of gravitate toward your world, and why is that the fit?
So, traditionally, I think because hospice in America preceded the specialty of palliative care. Specialty of palliative care really has been more in the forefront only in the past 15 to 20 years. Hospice has been around since 1982. So the largest percent of patients that we see are patients with oncologic disease or malignancy. However, many patients with heart failure, with end-stage lung disease, with end-stage neurologic disease, advanced vascular disease. These type of patients also have a serious illness. And they might have more than one serious illness. So patients with, post-stroke, for example, while you're working very much on the physical abilities by their, life space, you're working on their pain control, etc. There are things that from a psychosocial, emotional, functional standpoint that have affected the family that might be supplemented or synergized by palliative care.
So palliative care grew out of hospice, would you say?
Palliative care basically grew out of three things that happened in the United States back in the 80s. Hospice, of course, provided for more of what we call end of life or last 6 months, of care when patients elected to forego some of the aggressive treatments and really focus on being at home, not being in the hospital. So that preceded, but palliative care came about because, number one, patients began to realize that quality of life was suffering at the cost of quantity of life. Medical technology has been soaring over the past 30 years in what we can do to extend life, but those therapies come with consequences and side effects. And so symptom burden in patients that were not adequately treated, such as pain management, such as delirium, confusion, fatigue, those things have increased in frequency. And then the third thing is that we saw the aging of the boomers, like my gray hair that we see. We're aging, and as we age, we can tend to have more problems with frailty and decreased mobility and these type of things. So you're hit with an illness along the way, and you may need more symptom management and the psychosocial, emotional, spiritual.
I want to pick your brain for a little bit about pain. But before I go to that, I want to say, hey, if you have questions, if you want to type them in, I'll try to juggle reading them on my monitor and getting
Sure.
them to Rodney. But really, I think the people that are watching this, a lot of times there's questions and sometimes I'm not asking the right questions, but I hope to be. But I want to talk to you a little bit about pain, which is to say, because you've been doing this really since the inception of palliative care.
Really and truly, I was early.
Yeah, you
was
left
early.
in fact, you left your job as a primary care doctor to
Yep.
become a specialist in palliative
Yep.
in palliative care. But pain, we've sort of come full circle with our approach to pain medicine management. And so I'm curious how you have sort of walked the tightrope, if you will, between the problem with having patients with a high burden of illness that's causing pain and using opiates, which are potentially creating another illness,
Yep.
but also with their side effects and what types of medicines you have found to sort of hopefully help you skirt some of the problems with opiates. Because I would imagine your main drug for pain would be an opiate.
Well, so I think it's a great question, and I think we as palliative care specialists in both palliative supportive care and even hospice are actively addressing the issues. So let me back up for just a second. So the nation has come full circle. And I think some other specialties have come full circle in the way that we've approached chronic, non-malignant, non-serious illness type pain. Really, the specialty of palliative care has been pretty steady all the way through. We have always sought to have a multimodal treatment of pain because we know that physical pain that we can see because of a broken bone, because of a metastatic lesion in the bone, that we can see because of severe ischemia in a limb, that we can see because of neuropathy from neuropathic pain from side effects of chemotherapeutic agents, etc. We've known all along that it has to have a multimodal approach. So we have been aggressive in palliative care through the years to involve our pain management colleagues, to involve our physiatrists, to look at the effect of that pain on the psychosocial and the spiritual, because not all pain is completely physical. The pain can be exacerbated by anxiety, by depression, by existential suffering, about, spiritually, like why am I have this illness? And so we've really stayed pretty steady that opioids are not the only, treatment for whole body pain and those dimensions of suffering. Now, we have seen opioids are a mainstay of treatment for many patients, and I think that the message that we're promoting now is that yes, we should be assessing patients who are at high risk for abuse behaviors or addiction, absolutely. So we should be focused on very good judicious management of those patients, which may or may not include opioids.
Mm-hmm.
Okay?
I think your answer is very good in that it encompasses what palliative care is.
Yeah,
your approach
exactly.
to pain encompasses the very stuff that you said.
So we have a massage therapist on staff. We have music therapists. We believe incredibly about psychology, counseling, life coaching. We have a physical therapist. It's a manual physical therapist, that helps with patients. So we put all that together, and pastoral care, of course.
How do patients find palliative care? How do they get to you? Do they get to you through referral only, or do some patients seek you out?
Both. Self-referral from patients and families in the community who feel like their loved one needs something else. That's what a lot of patients are like. We're just not doing well. We've got 5 specialists, but, our loved one, or I've got 5 specialists, but I'm still extremely fatigued. I've got 5 specialists who maybe only offer another medicine or another opioid.
So are you saying that
Some patients self-refer in families, and then physicians, particularly in our Birmingham area, have learned a lot more about what palliative and supportive care can offer beyond what they traditionally think of as just quote-unquote end of life.
what is the awareness level amongst physicians? I mean,
It's growing. It's growing in the academic medical centers, which are really where the centers of much of the palliative care is. It's growing fast in our other hospitals, like in Alabama, particularly in Huntsville, Montgomery, Mobile, Tuscaloosa. There are now specialists that provide palliative and supportive care. So many times patients and families are more familiar with it during a hospitalization, because that's where the teams are more commonly that are able to help patients. But then they can transition to the outpatient setting.
Does insurance cover it?
Insurance covers it like every other
And is it
specialty.
is it hard to get it approved? I mean, if you're seeing
No.
so
it's a typical specialty. It's not a Medicare separate benefit like under Medicare, or like the hospice benefit or a rehab benefit or a bundled type of procedural benefit. It's strictly what we call through billing codes that are just like every other specialty. So it's a recognized specialty.
So is access to you easier, in fact?
I wouldn't say necessarily that it's easier. It could be in some ways, because we're not procedural based, which basically means we do a lot of cognitive evaluation, physical exam. We don't have to have pre-authorizations, as folks may be familiar with, for a procedure or an MRI scan or a PET scan. Usually it's a specialty. It's a recognized medical specialty. So if you, for example, said, I really think you would benefit patient X, Y, or Z from having an extra layer of care, just an evaluation by palliative and supportive care, you could do that, and then we don't have to have a pre-authorization.
Is there any? Do generally patients in palliative care then go into hospice, or are they in hospice and go into palliative care? How does that sort of? How do those
really
two?
Works
How does
both
hospice
ways.
and palliative care interface?
Ways. So palliative and supportive care in the larger medical centers and in some of our community-based hospitals, as I mentioned, become familiar and are introduced to patients during an acute admission. Okay, so and when we say during acute admission, this may be their new diagnosis of a serious illness. So they're certainly not at last 6 months of life, which is the hospice criteria. So they may be seen by palliative care in the hospital and then arranged for follow-up in the outpatient setting. It may be that palliative care sees a patient in the hospital and then makes recommendations to the primary care or to the Dr. Goodmans, to say, hey, this is what we would sort of recommend, and then you can refer them back to us. But as patients who do have serious illness progress to a point in their journey where they have elected more for comfort-based care, home-based care, and they seek not to focus on some of the aggressive measures or aggressive things that may not be beneficial to them, then at some point it may be appropriate for a hospice referral, which is a insurance benefit, which is an interdisciplinary team of individuals that base your care at your home or in a nursing home, and that's your location of care. So hospice has more of a location of care sort of connotation to it, but a lot of the same principles.
How and I'm going to end here, okay? But a great website that a friend of mine actually told me about was www.getpalliativecare.org. www.getpalliativecare.org. How do patients locally in this area find you?
So if you're in the Birmingham area or the 5-county area, really central Alabama, we have a website also, and you can just Google it. It's the UAB Center for Palliative and Supportive Care. There's also through the Alabama Department of Public Health, which is ADPH, there is a website section in the Alabama Department of Public Health that not only defines what palliative care is, but also links it to national resources and other statewide resources in addition to this, the getpalliativecare.org. The website, getpalliativecare.org, really explains more about what palliative care is again. It gives some questions and frequently asked questions and answers about it. But really for local resources, it's just, Google search.
Awesome.
Palliative care.
Awesome. One day I'd like to, and again, this is a work in progress, but I would love to, show some of do a Doc Talk Live with the other, not just the medical side of things, but the 4 pillars, if you will, the spiritual side, the psychosocial side, the emotional side. If we could somehow maybe be a part of a team conference,
that'd be great.
Would be very interesting. All right,
we'd welcome that.
Okay. Well, Rodney, thanks so much. I enjoyed it.
Brad.
It's a pleasure to
see you. If you
see
have other
you
questions,
again.
let us know.
Perfect. That would be great. So I'm going to hit finish.